This is the Blood Bank Guy Essentials Podcast, episode 047 CE. Welcome back to the podcast designed to help you understand the essentials of blood banking and transfusion medicine. I am Joe Chaffin, and I am still your host. Today, we're taking an in-depth look at a really controversial topic, transfusion-transmitted cytomegalovirus, or CMV, infection. There are many opinions and many thoughts about transfusion-transmitted CMV, and I'm going to explore them all with an expert in the field, Dr. John Roback from Emory University. But before that, here's some housekeeping. Continuing education for this episode is provided by Transfusion News at transfusionnews.com with generous sponsorship from Bio-Rad, who has no editorial input. The big news, though, that I have for you is that as of now, this and all of my previous continuing education episodes now qualify as self-assessment modules, or SAMs, for the American Board of Pathology. So for all of you pathologists out there, please pay attention to that if you need those. You can find all of them at bbguy.org/podcast, as well as iTunes and Google Play. Really, just look for any titles ending with the letters CE. If you've already received CME for any of those previous episodes, you should have already received updated certificates by email. Let me know if you have not. Now, this podcast offers a CE activity where you can earn the following types of credit. 1 AMA PRA Category 1 credit, ASCLS PACE Program 1 Contact Hour, and American Board of Pathology Self-Assessment Modules, yay, or SAMs, for maintenance of certification. To receive credit for this activity, review the accreditation information and related disclosures. Please visit www.wileyhealthlearning.com/transfusion news. Okay, now back to today's topic, which I'm really excited about it. At the AABB annual meeting in October 2017, the recently retired UCLA blood banker, Dr. Dennis Goldfinger, received the Emily Cooley Memorial Award, which is great. In his remarks, though, Dennis made what some of you might consider a heretical statement. I wrote it down so I wouldn't mess it up. So hang on. Here's exactly what he said. He said, "You can't get CMV from a blood transfusion." That's a direct quote. You can't get CMV from a blood transfusion. Now, I'm sure that not everyone believes that, but I wanted to repeat it so you would know that what we're going to talk about today, transfusion-transmitted CMV, is far from a settled subject. You have people who believe and practice in a wide variety of ways, and I can tell you that here in the U.S. anyway, nothing at all is settled. So my guest today is Dr. John Roback, who is professor of pathology at Emory University and a 2017 AABB President's Award winner. John was also senior author on a truly unsatisfying 2016 AABB committee report on TT-CMV that I wanted to discuss it with him. And don't worry, he agrees with that assessment, by the way. The report really illustrated the challenges that we have in coming to a concrete conclusion about the quote-unquote best way to prevent TT-CMV. Honestly, as we talked, I realized that we actually have slightly differing opinions on the subject, which is interesting. That's okay, though, because again, it just shows that well-meaning people can have different interpretations of the best way to do something. And I'll talk a little bit more about that at the end of the episode. So I'm super excited for you to hear this interview. So let's get started. Here's my conversation with Dr. John Roback about transfusion-transmitted CMV. Hey, John, welcome to the Blood Bank Guy Essentials Podcast.
Well, it's great to be here. Thank you so much for inviting me. You know, like I had mentioned when you first contacted me, it must have been like 20 years ago that I was one of the students at your Osler review course, and it was awesome. So I think this is great that I can actually help you do some teaching now.
Well, thank you for making me feel old right off the top of the bat, John. That's fantastic. I think this interview is going to go great. Well, that's very kind of you to say, and I really appreciate that. You have gone on to do great things in blood banking and transfusion medicine, and I'm really, really honored that you're here to talk to me today about transfusion transmitted CMV, a topic that I think both you and I have wrestled with over the years, and you have been involved in some not only some groundbreaking research, but also some committee reports and statements from AABB that we're going to get into. It's one of those things that I think we wish we could close the door on and say, oh, great, we figured this all out, we're done. But transfusion transmitted cytomegalovirus, John, I think you and I would agree that we're not where we would like to be in terms of having definitive answers. Is that a fair way to put it?
Oh, absolutely. It's one of those situations where down the line when we have, let's say, pathogen reduction methodologies that are approved for use on all blood components and are being universally applied, we'll never worry about transfusion transmitted CMV again. But until then, we're left with these, conundrums of, given our current approaches to prevent it, what's the best way to do it, or what's the best combination of ways to put together to, produce the safest blood product for our patients.
Absolutely. Well, so let us go down that path, John. But before we get to those options, I really want to take us back to the start, and let's talk about cytomegalovirus and what it is, what makes it unique, and why do we care about it so much in transfusion medicine. So, if you would just start us from the beginning, just give us some basics about CMV. What is this virus?
Right. So, CMV is a beta herpes virus, and like other herpes viruses, it can establish lifelong latency in the host. So, you get that initial transient infection, and if you're an immunocompetent recipient, you quickly bring the virus under control, but it persists, and it actually persists in one of the main reservoirs is in monocytes in the peripheral blood. So if you transfuse blood to another individual and that blood has CMV infected monocytes in it, then theoretically the virus can reactivate in the monocytes and in the transfused monocytes and infect the recipients. So and one of the things that one of the reasons I think of why this particular herpes virus is so so interesting, and why it still, sort of presents these conundrums to transfusion medicine practitioners, is because, first of all, it does remain latent in peripheral blood white cells, so it can be transfused. And secondly, we have a pretty good match between the percentage of the population that is CMV naive, that's never seen the virus and so has no immunologic response to it, and the proportion of the population who harbors CMV. Depending on the part of the country you live in, somewhere between, let's say, 40 and 70% of the donors will be CMV seropositive, will have previously seen the virus, but about an equal proportion will be naive to the virus. So if you contrast that, for example, with Epstein-Barr virus, EBV, one of the reasons we don't worry about transfusion-transmitted EBV, or don't worry about it much, is because 95% of the adult recipient population is immune, has already seen the virus, already made antibodies. But here in the case of CMV, we have a large population of adult recipients who are naive to the virus. So, and if that population of recipients, if they're not only naive to the virus, but they're immunocompromised, once they see the virus, they don't mount a good immune response, and now this opportunistic infection can cause significant morbidity and mortality in the recipient. So it's it's a very challenging virus from that perspective.
Well, so let's step back for just a second from that before we get into some of those details, John. Have we worked out? Is there science that tells us now what the stages of it, or if there are stages of infection for CMV, and if we can? I mean, are there different steps in the infection for, say, someone who's in the community and gets a CMV infection? Can you talk us through that a little bit?
Typically, what happens then is after the viral infection, there's a phase in which you can find CMV both in peripheral blood white cells and then also, though, as free infectious virus in the plasma. And as with many viral infections, you have this so-called seronegative window phase. So by the time these recipients typically have made an antibody, so by the time your serology turns positive saying this person's been infected, you've already had a few days to maybe up to a week or more where there's been free virus in the plasma and or CMV in peripheral blood white cells. So there you have that window phase. Now, that window phase occurs before the viral levels peak. So after seroconversion in most of these healthy immunocompetent recipients, you still see an increase in CMV viral loads, either free virus in the plasma or in the white cells, which then slowly goes away, but that can take, several weeks to months in some cases.
So I think that's really important to make sure that the audience is really clear on that. We have this tendency to think of CMV as a white cell virus, and it is, right? But there's also I think that the CMV being free in the plasma is something that is not always appreciated, and there's not really a question there, John. I just wanted to reemphasize it. I think that's important for people to get.
Yeah, that's absolutely important, because if it were only a white cell associated virus, we may not be having this conversation now, because you do leukoreduction, and in the U.S., some other countries are 100% leukoreduced. In the U.S., we're approaching that, but that would mean that doing a very efficient leukoreduction would eliminate the problem. But I think it's that free virus which can cause issues. And I did a literature search recently, wasn't able to find anything. But when early on in my career as a transfusion medicine physician, we actually did a couple quick and dirty studies and found that if we take a sort of a purified viral preparation and then put it through a leukoreduction filter, a lot of the virus makes it through the other side. So at least those older generation leukoreduction filters were not very good at efficiently removing free virus.
Can you talk a little bit about symptomatically what does that mean for an immunocompetent person? Is that person who doesn't have some issue with their immune system, are they going to know that they have CMV? Are they going to be wiped out? How does that work?
I think a large segment of the seropositive community, at least this is what I teach the residents and fellows, a large segment of the seropositive community probably never realized that they were infected. It was probably a relatively benign infection. Maybe they thought that it was just some kind of strange kind of viral syndrome they had that quickly went away. It's complicated. It does some it has some sophisticated ways of evading the immune system, but by and large, it's kind of, I would use the term a wimpy virus, in the sense that if you have an immune system that is functioning normally, the virus does not really represent much of a challenge to the immune system, and the immune system clears it pretty fast.
Okay. All right. So we've talked about the people that are immunocompetent and get CMV, and for our perspective for this discussion, we're going to consider those in the donor group, the potential blood donor group, because we're talking about transfusion transmitted CMV. So let's talk about the other end, the patients that are receiving blood potentially from someone from a donor who is CMV infected. What can you tell us about the spectrum of things that can happen to someone who receives CMV from a blood transfusion? Right.
Well, once again, if the recipient has a normally functioning immune system, if they're immunocompetent, then the risks are pretty low. They may have a transient infection, they may seroconvert, but not really a lot of concern. But on the other hand, if they're immunocompromised, if their immune system is not able to deal with this opportunistic infection, then there can be quite severe sequelae up to and including death. I think we'll talk a little bit later about a study that we were recently involved in looking at CMV transmission in low birth weight infants who were, immunoimmature, I would say, so their immune system had not fully developed. But we saw a substantial amount of morbidity in that study, and including infant deaths that were attributed to CMV. So, and the same thing can happen in adult immunocompromised populations.
And can you be specific with this, John? What adult populations are we worried about? What kind of patient groups should we be most worried about with CMV?
Well, in adults, the population that we normally get asked about is the bone marrow transplant population, and specifically, we're talking about cases where neither the donor nor the recipient has been previously exposed to CMV. So if you're talking about autologous transplants, then the recipient, who is actually also the donor, is CMV seronegative. But if it's allogeneic transplants, then it's a situation where both the recipient and the donor are seronegative. So in adults, that's the main population that we're concerned about. A smaller population would be, for example, patients with significant deficits in cell-mediated immunity. Normally, we discuss those with congenital defects in cell-mediated immunity. Although there could be some concern, for example, that patients with AIDS, for example, that have an acquired deficit in cell-mediated immunity could also be at risk, although, that I don't think has been as well defined. And then as we talk about groups that are immunoimmature, either very low birth weight infants, or in addition, cases of in utero transfusion. So there you have the ultimate immunoimmature recipient. So if you're doing, it's interesting, if you're doing in utero transfusions, that's the scenario where even a number of transfusion medicine practitioners who say, oh, it's not a situation we have to worry about, kind of pause a little bit and say, well, maybe for in utero transfusions, we have to do something special to prevent CMV transmission. So that's that's probably one area where most everybody agrees.
And one last thing before we move on from that, because we need to get to how we're testing our patients and donors and how we're trying to prevent CMV transmission. But before we leave this topic, I have heard the argument made in some cases from the stage at AABB annual meetings that we are how shall I put it, that freaking out about CMV is less of an issue than it used to be, or we shouldn't be so concerned about it because, for example, in bone marrow transplant and organ transplant recipients, those patients are being monitored incredibly closely for evidence of CMV infection. So, why are we even worrying about it from the transfusion perspective? And I just wanted to get your take on that, in particular with, that's probably true for bone marrow transplant, but is it true for all patients that could get CMV?
I would say it's not true for all patients, and even in the case of bone marrow transplant recipients, it might be true at some sites, but not at other sites. So, for example, if you are monitoring your patients, really closely, if every week you're testing for CMV infection, for example, and you're able to, as soon as you see a blip suggesting that the recipient has been exposed to CMV, either a blip up in CMV, plasma DNA, or whatever method you're using, then and if you're ready to jump on that immediately with antiretrovirals, then I think that you probably don't have much of a problem. And a few years ago, when I was talking with some people from the Hutch, that's basically what they do, and they're one of the biggest proponents of saying, let's just use leukoreduced blood and we'll be fine and we have nothing to worry about. And it's that combination, I think, in their population of using leukoreduction plus using really active monitoring where they've dealt with the situation. But if your particular center is not monitoring that actively, or if you're concerned about other patient populations like low birth weight neonates, for example, then I think it is something that still needs to be considered. I can tell you in the case of some of our big obstetrical practices in the Atlanta area that they're very wed to the practice of using both seronegative and leukoreduced blood, just because they're so concerned about any of their patients contracting CMV infection from transfusion.
When we are testing blood donors for CMV, what kind of test or tests are we doing?
So right now, when we're testing, essentially the only test we have to identify a donor who might be high risk versus low risk is serology. So what we're looking for in that case is we're looking for the presence of antibodies against CMV, indicating that individual's previously been exposed to CMV. Now, of course, there are nucleic acid-based tests to detect CMV, and those tests are used a lot, for example, in organ transplant recipients. But those tests have not been applied widely to the blood donor population in order to identify donors who are relatively higher risk or relatively lower risk. That's something presumably that could be done. I've heard some discussions about doing the studies, but at this point, it's not something that's really been done. So if you turn to your blood center, for example, they'll be able to get you CMV seronegative blood, but if you ask them for CMV DNA negative blood, they just laugh at you because it's not routinely available.
Okay. So is it fair to say that when you get a unit of quote unquote CMV seronegative blood, that there are several possibilities for that donor in terms of what their actual status is? Absolutely.
Yep. If somebody is CMV seronegative, and this is just a classic example of the viral window period. And this is the same thing that applies to, for example, the window period for HIV or Hep C or any of the other viruses, which is that the virus is there and it's circulating before the recipient has actually mounted a measurable immune response. So somebody who's CMV seronegative could truly never have been exposed to the virus, or they could have been exposed to the virus relatively recently, and they could have free virus, potentially infectious virus in their plasma, or they could have viral DNA in their white cells ready to replicate before they've actually made the anti-CMV antibodies. So that would be the window period when the patient is or the donor is infectious but has not yet mounted an antibody response.
And so for everyone listening, I am going to do everything I can to get an image that John and Cassandra Josephson, another friend of the podcast, put in their article, their editorial, from 2013 in Transfusion, that shows what John is describing so super well. I'm going to do everything I can to get that on the website. So I've said this to you before, John, but I think that is perhaps the best illustration I've ever seen to make it clear to people trying to learn how CMV works. So great job on that.
Right. Well, thank you. I appreciate that. And the one thing I would mention, to students and, residents, other trainees out there is if you look at that figure and if you just delete the dotted curve in that figure for white cell associated CMV, then it could apply to virtually any other virus that we're worried about in transfusion medicine. The thing that's a little bit different about this is we also have that period of white cell viremia.
Okay, so that brings us, John, to the time when we need to lay out some alternatives. So I will lay this wide open for however you want to approach it, but there have been at least a couple of different approaches, potentially three, I guess, if you include both of those approaches. But take us through what are the options to try and protect those vulnerable recipients from transmitted CMV?
Right. Well, so there's really three approaches that are in standard use in the U.S. One of them is serology, so order units that are CMV seronegative. The caveat there is you may have some window period donors among the seronegative. The second option is to order leukoreduced units, and that's also highly effective, although the caveat with leukoreduced units is, as I had mentioned earlier, at least when we looked at it before, the filters don't do a great job removing the free viral particles, and so if you have a big spike in CMV virus and you leukoreduce, you might still get some virus making it through. And then there's also a concern, although we think it may not be as big a concern in this day and age, but there's also a concern about filter failures and whether you might have a donor whose white cells, where the filter failed, you got a lot more white cells into the product than you thought you would, and some of those white cells have latent CMV that can reactivate. So there's leukoreduced units, and then there's what some people have described as the belt and suspenders approach of using both seronegative and leukoreduced units.
I guess, John, kind of by default, if you're practicing in a country that does universal leukoreduction, if you get a unit that's seronegative, you're probably doing that, whether you're ordering it that way or not, right?
Exactly. That's exactly right.
I want to make sure that people understand something really, really important here. And you hit that really well. You've got potential issues with seronegative units with window period type infections. You've got potential units with issues with leukocyte reduced units of a plasma CMV viremia that would not filter out, or potentially filter failures, which I agree is less of a concern, but still potentially there. But John, what you're telling me, and I want to make sure that I'm understanding this in our audience, is that neither method is perfect. Is that true?
I do believe that's true. So for example, if you look at it from the perspective of serology, I mean, that's generally accepted that the seroconversion happens after there's already CMV in the blood. Now, the leukoreduction failure is a little bit harder to pin down, because in the days when when most experts quoted the risk of CMV transmission by either leukoreduction or serology used separately, they typically quoted at 1 to 3%. And the reason that we thought at that point that there were significant episodes of filter failure is just because if you look at the data from sort of the classic randomized controlled trial by Bowden, which was published in the 90s in Blood, that's kind of the rate that they were seeing. And but what's important to remember about that is back in that day and age, first of all, the filter technology was for the blood filter technology was kind of in its infancy, and a lot of filtration happened at the bedside, so you were dependent on nurses, for example, some of whom may not have been well trained in how to put the filters together. You were dependent on the nurses actually doing the filtration. And so back then, I think that there was more of a concern. We've talked a little bit about the study I was involved in. I guess we'll be talking about that more. But in that study, we did a very detailed analysis and of the possibility of filter failure, and it's an extremely, extremely rare event. In fact, we didn't really find anything that we would call an overt filter failure in that study.
Okay. Well, so we will, you've teased that twice, so we will get to that. I swear we will. Give me just a minute. We'll get there. But before that, John, I think it's important for everyone to understand that, and okay, I'll be slightly tongue in cheek here and I'm going to poke at you a little bit. So forgive me that in 2016, you were senior author on an article published in Transfusion, that was titled AABB Committee Report Reducing Transfusion Transmitted CMV Infections. And I dare say, John, that has answered every question that we might have. Is that right? I
would say actually it pretty much answered none of the questions we have. In fact, what was interesting about this study is that yeah, right, that was 2016 in Transfusion. What was interesting is that the AABB leadership said to our committee, the Clinical Transfusion Medicine Committee, or CTMC, they said, you guys did a great job putting together practice guidelines for plasma transfusion, for red cell transfusion, for platelet transfusion. Why don't you guys go ahead and tackle prevention of CMV transmission? And once we started looking at the data, we basically said the data comparing leukoreduction with serology to prevent CMV transmission were of poor quality. There were no studies of significant size that had been performed in at least 10 years, that there was extremely wide variation in practice, and that there were other approaches that could be used that hadn't been tested. And so we said, we just don't think it's worth AABB's effort to put together clinical practice guidelines because they'd be of very low quality. So rather than that, we just, put together this committee report and tell you what we thought the state of the art was, for understanding transfusion transmitted CMV infection. And that state of the art was pretty poor.
But by the way, I tease you, but I would actually highly recommend to folks to get a copy of that if they have not seen it, simply in order to get, as you said, the state of current practice, because I think there's a ton of great information there. I don't mean to mess with you too much, John.
No, you're absolutely correct. I mean, once we started looking at it, we said, we won't be able to produce guidelines that'll help any practitioner at all.
What exactly is the problem that we see now with some of those older studies regarding leukocyte reduction versus CMV seronegative?
the main problems, I should say, with the old studies, as I see them, are the technology being used. Back then, the leukoreduction technology was not quite as sophisticated as we use now. For example, in some of those studies, they were still using bedside leukoreduction. And also, as you look at some of those studies, they described the leukoreduction filters they use as quote unquote 3 log filters, and now we're at least a log or more beyond that. So we're getting rid of 10-fold more white cells at least in the current day and age than we were back then. So that's with that's in terms of leukoreduction. Then in terms of the serology, many of the studies back then utilized things like particle agglutination or hemagglutination, and now we have much better ELISA-based assays. So I think that there were probably, in some of these older studies, there were probably, in terms of the serology, problems with false negatives, maybe false positives, and just generally less reliable assays than we currently have access to.
I don't know that I want to challenge you on it, but I want to at least get your thoughts on your feelings on the study that was published in 2011 in Transfusion from Thiel et al. that looked at a population of stem cell transplant recipients who got purely leukoreduced blood products not tested for CMV, and their conclusion was that it worked really well. I wondered if you had any thoughts on that particular study and how much that study went into your committee report discussion.
So we did talk about that study, which was a prospective observational study, and the conclusions from that study, I think, were pretty strong. In that study we had 23 CMV seronegative BMT recipients who received transplants from CMV seronegative allogeneic donors, and in total those 23 patients received 1,800 blood products, and none of them developed CMV-associated clinical complications. None had detectable CMV DNA, which led to a calculated risk of TTCMV of 0% in their study, which with a 95% confidence interval of 0 to 0.12%. So once again, it was a well done study, and if a practitioner wanted to look at that study and essentially say, there's no risk with the transfusion of leukoreduced, non-serologically tested blood products, I think you could use that study to defend it. It is only one patient population, so it doesn't address other at-risk patients. And so I think that is an issue. The other thing to keep in mind with this study, and I don't have any really good data to argue one way or another on this, but these patients received a lot of blood products in this study, and along with those blood products, they received a lot of passive CMV IgG antibody. So that, in some ways, could have been protective. In fact, more protective than, for example, if you use this methodology, just leukoreduction, not serology. If you were to use this methodology for other patient populations that may only receive 1 or 2 blood products, maybe in that setting, if you transmitted CMV in the absence of antibody, you could get a different result. So that's just something to consider. But clearly, for a heavily transfused population of immunocompromised BMT patients at risk for CMV transmission, this study suggested that just using leukoreduced units was highly effective.
I would like to move on from here, because I think you've made a ton of excellent points, and all the details that you've given are great. I would like to move into some of the more recent stuff that has been done, and I am finally going to let you talk about your paper that was published, I believe, in JAMA Pediatrics in November of 2014.
That's correct.
Cassandra Josephson was the first author, and you were the senior author on this paper. So take us through it, John. Who were you looking at, and what were you guys trying to do?
Right. So in this particular paper, we wanted to study transfusion-transmitted CMV infection in one of the high-risk populations I talked about. So in this case, very low birth weight infants. And initially, when we started designing this studies, our hope was to sort of replicate the Bowden study, have two arms, make it a randomized controlled trial, have two arms, and one where the babies received just seronegative blood, the other one where they received just leukoreduced blood. The problems that we encountered doing that, though, were, first of all, the study was going to have to be quite large, and so in order to do that, we actually had to recruit 3 separate hospitals in the Atlanta metro area. So we had to go to those 3 hospitals. And one of the things we found out right at the beginning, and Cassandra did just an unbelievable job organizing this study, is 2 of the hospitals said, we are using leukoreduced and seronegative blood, and there's no way we're changing for your study. So that quickly eliminated the possibility of doing a randomized control trial of any sort of meaningful size. So what we did then is we pivoted a little bit and said, well, if we can't do that, then why don't we look at do an observational cohort prospective study and look at what happens if all of the very low birth weight infants at all of the sites received seronegative and leukoreduced blood. And so that's what we ended up doing. Now, one of the things that was interesting about this study is that it was designed very rigorously to try to track every single avenue of potential CMV transmission. So, for example, all of these babies were in the NICU. And so one of the things when you look at the old studies, if you're so inclined to pull up some of the older studies, looking at the rate of transfusion-transmitted CMV, even the ones, in a bone marrow transplant population, it was very difficult in those studies because a lot of the patients were followed after they left the hospital. It was very difficult to quantify community-acquired CMV, which is a real risk. In our study, because the babies that were on study spent most of their time in the NICU, we think we did a pretty good job eliminating the risks of community-acquired CMV infection. The other thing we did in this population is that we carefully tracked CMV transmission by breast milk. So we got samples of breast milk that was fed to the babies, and all that breast milk was all of that was tested for CMV by PCR. So we looked at breast milk transmission, and then all of the blood products that were transfused to the babies were tested both for residual white cells to try to rule out filter failure, and then they were also tested by PCR to try to identify cases of CMV virus in the plasma. So that was the general framework for the study. We ended up, at the end, we had 541 very low birth weight infants that were accrued into the study. 310 of them, or 58%, received at least one transfusion. There were a total of just over 1,000 blood products used for transfusion. And as you know, those of you that have worked in pediatric hospitals or studied transfusion on the OB services. In many cases, the products come from the blood center, and then the blood banks split them into smaller products. So those just about 1,000 cellular blood products were actually divided up into just over 2,000 different transfusions. There were about 1,500 red cell transfusions, 380 platelet transfusions, 130 FFP transfusions. So we really tracked all of this closely. I talked about, filter failures. We only had one case of all these units that were transfused from 1,000 cellular blood products. We only had one case where you would technically have to call it a filter failure. That's why I sort of hedged on when you asked me that question earlier, do filter failures still exist? Pretty rare with our current methodologies.
Got it. So what did you find, John, in terms of the babies that did get CMV? Was there a particular theme to how that actually happened? Or were you able to figure that out?
Yep, absolutely. So what we found was that 29 of the infants we enrolled in the study became infected with CMV, and interestingly, all of them were born to CMV seropositive mothers. So of the 127 seronegative mothers in our study, none of the infants born to them contracted CMV. So what that said to us was there were essentially no cases of community-acquired CMV infection, no cases of transfusion-transmitted CMV infection in that population, and obviously no cases of breast milk transmission. But all 29 cases happened in seropositive mothers. And there were about 412 seropositive mothers. So that was an incidence of about 9% CMV infections in babies born to seropositive mothers. And that indicated that in this population, the key pathway, if you will, or the key method of CMV infection was via vertical transmission, either transplacental or breast milk. But then we tested all of these babies right after birth for CMV infection, and in almost every case, we ruled out vertical transmission or transplacental transmission, I should say. We only had one example of that. So we think that almost every case, 27 of the 29 cases, were due to breast milk transmission. And that was based on not only our ability to identify CMV in the breast milk, but also to rule out the presence of CMV in these other sources. So the conclusions from this study were that we saw no cases of transfusion-transmitted CMV infection when the infants were uniformly given seronegative and leukoreduced units. So one of our conclusions was from the transfusion medicine perspective that the use of seronegative and leukoreduced units is highly, highly safe when it's being used for a susceptible patient population.
So the devil's advocate in me says, okay, John, that's great. Is anyone taking that forward and looking purely at leukoreduction without the seronegative, or is that a study you can do?
So it is a study that one could do. It would, I think, be a very large study, and in fact, Cassandra and Megan Delaney published a paper in Transfusion just recently, which was a pilot for that kind of a comparative effectiveness study. And as you know, Megan is out there at University of Washington, where there are big proponents of using leukoreduced only for their bone marrow transplant population. So that could be one site where one might be able to do the same kind of study on very low birth weight neonates.
Well, we said from the beginning that that there's no absolute standard anywhere. But let me ask you this, and this is just so everyone will know, this what I'm about to ask Dr. Roback, is not for John to say everyone should do it this way. But in your personal practice, John, at Emory, how do you handle very low birth weight babies and CMV prevention?
So what we do is, with very low birth weight babies, we do use both seronegative and leukoreduced units. Now, that has to do with the fact that these babies are not, they're not monitored, on a very intensive basis for CMV infection, and there are some risks using antiviral medications, in this population. So for those babies, that's what we do. Now, for the So my personal approach, and this is, once again, very individualized, but for the adult recipients, if it's say either a bone marrow transplant patient or a solid organ transplant patient, even and including cardiac and lung transplant recipients, if either the donor or the recipient is CMV seropositive, then we just give them leukoreduced units. And if they ask for both seronegative and leukoreduced, we talk with the clinicians, we explain these data, and we say, if your patient were to contract CMV infection, it would come from either the recipient of the transplant or the donor, but it would be highly unlikely to come from the blood product. And in most cases, they say, okay, thanks, and they go ahead with the leukoreduced units. However, in those populations, if we have a transplant, individual where both the recipient and the donor are seronegative, and if the clinicians ask specifically for seronegative units, then we do give them both seronegative and leukoreduced units. And I typically cite this data and say, I'd like to be able to say, it would really make my life a lot simpler to say that I'm sure leukoreduced units are plenty fine, but the data we have only tells us that units that are both seronegative and leukoreduced are highly safe. And so for our most at-risk patients, that's what I would give as a CMV-safe unit.
Okay. So let's continue with this scenario. Let's imagine that you're in that situation, and as we're recording this, it's January 2018. The East Coast is in the middle of horrible snowstorms and terrible weather. There's flu all over the country. Donations are down. We're in a fairly significant crisis mode right now. I think you know where I'm going with this, John.
Right.
So suddenly you're in that situation, and CMV negative units are not available. What do you tell your clinicians then?
Yep. And so what I would do is I would go through the same kind of explanation we've just gone through, and I'd say, under ideal circumstances, I would try to obtain for your recipient units that are seronegative and leukoreduced. Obviously, with the weather, with the donations down, we're not in ideal circumstances. The data suggests that leukoreduced units are still very, very safe, and you and I really need to discuss how urgently the patient needs transfusion. If they need blood soon, the next 12 hours, 24 hours before we could reasonably expect to get seronegative and leukoreduced units, then I would say, no question, let's transfuse them with leukoreduced units, because the risks of them foregoing transfusion are a lot greater than the risks of contracting CMV from a leukoreduced unit. But, if you can wait and we have a reasonable expectation that we'll get leukoreduced and seronegative units in the time frame you can wait through, 12 hours, 24 hours, whatever, then go ahead and wait. And when we get those units in, we'll give them to your patient. And if we reach that point and the units still haven't arrived for whatever reason, then we'll revisit the discussion. But I certainly wouldn't forego transfusion waiting on seronegative units.
Right. Okay. Well, I really appreciate that perspective. I think that, to those of you that are listening and are sitting there right now going, give me rules, give me specific hard and fast things to follow. John, I'm pretty sure I can speak for you when I say that, you know what? Each facility has to decide, has to look at the data, has to talk with their clinicians and decide exactly how you want to handle this. Is that a fair way to put it, John?
That is absolutely true. I mean, there's a big gray area here, but there are gray areas in many of the questions that we deal with in transfusion medicine. And when I enter those gray areas, that's when I really like to, pick up the phone, talk to the clinician, make sure they understand my perspective. I want to understand their perspective, and then collectively we'll reach a decision.
All right, John. So before we go, I think we've covered so many details, and it's awesome. I would like to just hear from you a little bit on the way that some other people are handling this, potentially like in other countries or different approaches that have been defined other than our kind of three traditional ones, and just get your take on some of those. So the first one that I want to make sure we cover, and you can go from here to wherever you want, but there's an approach that's been out there that people have talked about using specifically seropositive units in donors that have been positive for a long time, like a year or more. Can you talk through that a little bit and how that might work in the United States?
Sure. So this was a study. This came out of a study that was performed by Zeman and colleagues, published in Transfusion in 2013, and what they did is they turned the whole problem on its head, and they basically said, okay, if somebody has, if we look at serology and we realize that right after somebody seroconverts, they still have a ways to go, several weeks, even a couple months, where they're going to have CMV viremia, either virus in the plasma or viral DNA in their white cells. But then if we wait long enough, and what Zeman did is they waited a year, if we wait long enough, then that initial phase of viremia has been cleared, and now that donor should have little or no CMV DNA remaining in their blood. And in fact, what Zeman postulated at that point was that the only risk would be transient reactivation of the virus. So what they proposed doing then was waiting a year after seroconversion and then accepting all donors who'd seroconverted a year later, or a year or more previously, I should say, as being CMV-safe. And I've heard that that's an approach that is being used in some other countries, and it'll be interesting to see what what impact that has on CMV, on the risks of transfusion transmitted CMV in those countries. The problem is that you would have to operationalize that into your blood center processes, and what I can tell you is if you called up your blood center someplace in the U.S. and said, "Hey, I want a blood product from a donor who has been who's seroconverted at least a year ago, and I want that blood product leuko reduced," they would have no mechanism for finding such a donor.
We would stare at you blankly. Yeah. That's what we would do.
Yeah, exactly. It's just it hasn't been operationalized, and there's no really good way to do it. So in theory, I think it's a really interesting approach that could be explored further in the U.S., but it's just not something that we're capable of implementing in this day and age. There are other things we could look at too. We could look at adding CMV-NAT on top of serology, or adding CMV-NAT to leukoreduction, or adding CMV-NAT to the Zeman approach. There's a lot of different potential combinatorial ways that we could look at this, and if you're able to either get that figure we talked about earlier up on the website, or at least put a link to the editorial, then I think that the listeners can go and look at that article and see some of the interesting ways that these methodologies could be explored to sort of further provide CMV-safe units for the at-risk patients.
And I guess we could kind of close by saying, John, that what you said earlier, that once pathogen reduction technology is in place for all products, and to be clear, everyone, at this point, we can do it for plasma, we can do it for platelets in the United States, but we can't do it for red blood cells. But once that is in place, then this whole discussion goes away, right?
Absolutely. And the virus is, extremely susceptible. I'm sorry, I meant to say pathogen reduction. The virus is extremely susceptible to inactivation using those methodologies. So, once we get pathogen reduction that can be applied to all blood products, then the problem goes away. But until then, it still, provides fodder for these kind of discussions.
All right, John, it's just been an amazing discussion, and I really appreciate you taking on this topic that I guess I'm sad to say for both of us that there are no definitive clear answers yet, but nonetheless, I think you've done a great job at talking us through the possibilities. So thank you so much for being with me.
Yeah, my pleasure. I mean, I sincerely wished I could have given the people listening a clear-cut answer, but in the absence of that, the best I could do is explain the data as I know them and let people make their own conclusions.
So I mentioned at the top of the podcast that John and I have slightly different views on TT-CMV prevention. And as you heard, John generally thinks that CMV seronegative and leukocyte reduced is the best option. That's the so-called belt and suspenders approach, as it's called. While I've stated multiple times, including most recently in episode 044 CE, during my discussion with Pat Kopko, my personal belief that modern pre-storage leukocyte reduction is sufficient to call a product CMV-safe. But as I said, just because we differ somewhat doesn't make me right and John wrong, or I hope vice versa. It just shows where we are, as illustrated by the lack of conclusive evidence in the literature. And remember, I started this whole thing with a quote from a highly honored transfusion medicine physician who said, "You can't even get CMV from a blood transfusion." Just a reminder, the continuing education credit is directly found at wileyhealthlearning.com/transfusion news. I really hope that you'll give your feedback and any comments on this particular episode at bbguy.org/047. And you can also go through iTunes or even use the direct email comment@bbguy.org. I've got some great interviews coming up for you, including the next episode, which is an interview with Dr. Steve Frank from Johns Hopkins on bloodless medicine. After that, Dr. Jeff Winters from Mayo Clinic returns to discuss more therapeutic apheresis topics, and then the incredible Sue Johnson from Blood Centers of Wisconsin will thoroughly explain pre-transfusion testing. And really, remember, my goal is always just to come alongside you and help you understand the essentials of blood banking and transfusion medicine. So until we meet again, my friends, my hope is that you'll smile and have fun, and above all, never ever stop learning. We'll catch you next time on the podcast.